Morning, everyone. So my topic of discussion is evaluation of cross-linking of donor corneas following therapeutic keratoplasty in cases of infectious keratitis. So graft infection following therapeutic PK is a serious post-op complication and which is characterized by microbial colonization and inflammation of the transplanted corneal tissue. Recurrence rate post-therapeutic PK is around 27.5% and 10.1% in fungal keratitis. And it can arise due to a combination of preoperative, intraoperative, and post-operative factors. The preoperative factors include the presence of active microbial keratitis, especially if the infection is not fully sterilized before surgery, poor ocular surface, dry eye disease, or lid margin disease. Or intraoperative factors can be because of the contamination can occur due to inadequate sterility, incomplete excision of infected host tissue, residual exudates. Post-operative factors can be delayed epithelial healing or non-compliance with antibiotic regimens. So PEG-CXL, basically it is used in active keratitis to reduce the infection as it improves the covalent bonding, also improves the tissue resistance for enzymatic degradation. Photoactivation of the riboflavin oxidizes the chromosomal strands of the pathogens and helps in controlling further progression of infection. So there are some evidence from the previous studies as Khandelwal et al. Conclude that pre-treatment with PEG-CXL in conjunction with Boston type 1 capro seems to be safe and effective adjunctive treatment for achieving increased vehicle donor corneal rigidity. And Titial et al. Found that in CXL treated group, there were no graft infection at 6-month follow-up, and in non-CXL group, 6 patients had graft infection. So chances of infection vascularization can be significantly reduced with CXL treated donor corneas. So hypothesis is that the CXL helps in have antimicrobial effect in infection, and it improves the biomechanical strength, and it decreases the chance of infection with CXL after therapeutic PK as it sterilizes and strengthens the recipient bed. We done a prospective study which was done at RP Center for Ophthalmic Sciences, AIIMS, New Delhi. Ethical clearance was obtained. The inclusion criteria includes corneal ulcer, which involves the more than 2/3 of corneal thickness and large ulcers. Age should be more than 18 years, deep corneal abscess or impending perforation or perforated corneal ulcer, and patient willing to give consent and participate in the study. And we exclude the patient which have endophthalmitis or immunosuppressed patient and one-eyed patients. So comprehensive preoperative evaluation was done. Normal therapeutic PK as per standard protocol was done. In bacterial keratitis, we take the clear margin of at least 0.5 mm, and in fungal, 1 mm. The collagen cross-linking as per accelerated protocol, 9 milliwatt per centimeter square for 10 minutes was performed after the therapeutic PK. So we did the cross-linkage after the therapeutic PK. I'll show the video in later state as well. So the demographic details was done. The baseline clinical details such as size of the ulcer, culture, and was taken, and follow-up was done, which includes the graft clarity, clinical photo, complication, and treatments and time to healing. The primary outcome measures we did that was done recurrence of graft infection, and secondary outcome was anatomical success and the graft clarity. So we found that mean age of the patient is around 54 years. Most of the patients are male, and the maximum patient have the non-healing ulcer or perforated corneal ulcers in which the therapeutic PK has done. So the complication, we found that recurrence of infection at 1 month, the 4 patients have the recurrence of infection, and donor corneas which are treated with therapeutic PK, which are treated with CXL after therapeutic PK have 4 unresolved graft infection. These are the some clinical pictures was done of therapeutic PK CXL. At 6 months, we can see that there was no infection, and the one patient also underwent in the under optical penetrating keratoplasty post therapeutic PK, which is doing really well. And these are the patient which have infection after therapeutic PK in which CXL was not done. So to summarize, therapeutic PK CXL is a safe procedure and does not confer any additional risk as compared to therapeutic PK alone during therapeutic PK CXL. In vitro assessment shows promising results for Pseudomonas aeruginosa, and ultraviolet CXL is a safe procedure that does not affect cell viability and collagen degradation. Thank you.
Finished right on time. Very good. So my question is that these patients, they develop graft infection, and then for which
yes,
you, yeah.
We see these patient does not compare to normal patient in which therapeutic PK was done, and the other group in which therapeutic PK with corneal cross-linking was done. So they develop less graft infection
At what time did the cross-linking get done?
immediately after the therapeutic PK.
So
In
the
same
corneal
sequence.
transplant followed by cross-linking
Yes.
to take care of the primary infection. And you got better results in the transplanted eye. So what is the hypothesis behind which I didn't see that.
Ma'am, corneal collagen cross-linking itself increases the covalent bonding, which increases the rigidity of the corneal tissue. So it strengthens the corneal tissue, and due to which it reduces the degradation, enzymatic degradation. And also we use the ultraviolet light rays, which can directly damage the microbial organism.
The objective of the study, was it to see the graft resilience, or was it to show that you can eradicate the infection better?
We look for whether the patient develop graft infection post-therapeutic PK less in these group or not.
Okay. The only problem here is that when you compared it with the other group, right? In
Yes.
which you didn't do cross-linking. So, but you couldn't compare, you can't control the infections in the sense that the group that you had, whether they were all fungal or all bacterial, in both the groups. Did you match that as well?
Yes, ma'am.
You can't get your slides, you'll have to just answer that.
We also did the
Okay,
culture.
all right, yeah, okay, good, thank you.
I would have thought that comparing treatment of an ulcer after it develops with cross-linking would have made more scientific sense to me.
Sorry.
In this
ma'am.
case, you're obviously not irradiating till the endothelium.
No.
So your primary aim is to prevent a secondary
Secondary
infection
infection in these
So
groups.
what was your longest follow-up of these cases?
Almost, ma'am, after 2 years, most of the patients are doing well, and they are already, some of them already underwent optical penetrating keratoplasty, which they were doing.
Yeah, good concept, yeah, thank you.